community health centers, by and large, are not going to be able to do it all by themselves the way they did back in the 1960s, digging wells and building privies and doing the urban equivalents that any of those first 5 or 6 or 10 health centers really undertook. There are some things that we'll be able to do ourselves, but mostly we're going to have to do this in collaboration with other agencies, other institutions, and we are ourselves now a major institution on this scene nationwide, and other agencies, both public and private. So we're going to have to really enhance what we started to do, which is collaboration with public health departments, with housing departments, with environmental protection agencies, with private foundations, with private donors, all of the things that we'll need to put together to intervene in the factors that are in fact determining the health of so many populations, particularly those at the bottom end of income and opportunity ladders. Community health centers were invented to reunite public health and clinical medicine that had been separate for so many reasons for so long, to allow clinicians and their institutions, community health centers, to think about these social determinants of population health. Indeed, to think about population health as an entity in its own right that they had to be concerned with, and public health people to return to clinical medicine. I will never forget wandering around Boston and seeing the early versions of a predecessor of community health centers called the George White Health Centers in Boston. And engraved in stone on one of their buildings was their slogan, which was, "No diagnoses made, no prescriptions written." They were so timid about infringing on clinical medicine and stirring up clinical opposition that they siloed themselves. And that started to break down. Community health centers have done a lot to break it down, but we're going to have to do a lot more. And there are instances, I know, in your turf in Seattle and other places in Chicago and in New York, where, for example, in managing the great problem of asthma in individual patients, jointly with public health personnel, going after the housing triggers, the environmental triggers that are such a great part of this. There are places where public health workers are not only cleaning out the triggers in all of those asthma patients' houses, but teaching the families how to do that. Or in Chicago, where the public health department has been providing vacuum cleaners for the families of asthmatic children to help accomplish the same thing. And those are just beginnings of the kinds of collaboration that I think can be undertaken. That's been a goal and a problem, as you know, for so long. Coordination between community health centers and hospitals, bridging the competitive aspects that get in the way of that, struggling with the problem of a fragmented healthcare system that is struggling hard now in this new era of expansion to buttress primary care, but doesn't adequately cover for vulnerable populations the whole, unless they're over 65 or in a few other special categories, the whole problem of specialty care. So I think that's going to take a lot more work. But the further we move from procedure-based, fee-for-service, competitive arenas of medical care between community health centers and hospitals toward the goal of what's variously called a high-performance healthcare system and a quality-oriented, outcomes-oriented healthcare system, the balance is going to tip toward some more rational form of coordination, which is going to take a more rational form of funding for those purposes at least. And that's a task that lies ahead for the whole healthcare system and for the larger political system as well. Well, I think we're going to do it in collaboration, first of all, with the range of governmental and non-governmental organizations that are serving those populations. I'm sure it's not just HRSA, other major government agencies that are involved one way or another in migrant health, environmental protection to name the first and most obvious one that comes to mind, but not just them. There are private organizations like NGOs like Healthcare for the Homeless, and a whole variety of locally based outreach efforts to reach the homeless. We need well worked out modes of collaboration with them. And this has been difficult because everybody is so busy taking care of patients and checking the revenue streams and worrying about quality, all of the clinical components of our care. And we're just going to have to find the resources. I see all of this as a part of addressing population health, and for these special, highly vulnerable populations as well. And you know, if you want even higher risk than migrant health workers, I think it's migrant health workers' children. Again, there are both NGOs and government agencies and local organizations that maybe we can work with. Part of them, given the priority of clinical care and competence in clinical care and patient-centered medical home, if you will, that has to have priority, and we can't abandon that. But neither do we have to think, as we did in the beginning, the very beginning, that we can do it all ourselves, because we can't. And sometimes we're going to have to seek collaboration, and sometimes we're going to have to beat on people and organizations for collaboration. But that landmark task has changed some. When we were having the groundbreaking for the new health center in Mount Bayou in Mississippi, to my astonishment, and they had a big formal ceremony and a tent and all kinds of people invited and an all-day reception and lots of talks and speeches, but also literal groundbreaking with shovels flinging dirt. And who was there for the whole day, flinging dirt with the rest of us, making a good speech, staying for the reception, interacting with everyone, being hugely supportive, was the Republican junior U.S. Senator from Mississippi, Roger Wicker. If anybody had told me in 1965 that the next time we built a big new health center unit, a Republican United States Senator from Mississippi was going to be an enthusiastic participant, I would have asked him what he was smoking that day. But here he was. And while we probably disagree on 98% of the things that he supports, he thinks community health centers are the best thing ever invented. That wouldn't have been possible not so very long ago.